All right, welcome to day 5 of our CCRN exam review prep class. My name's Noah Dagan, and we're going to be talking about respiratory today. There's a lot of topics in respiratory, and it's a large part of the exam. It's very similar to cardiac in that. And so here are some of the things we're going to be talking about. We're going to talk about ventilation physiology, so kind of how the body uses ventilation to pull in oxygen. We're going to talk about pulmonary volumes, how much the lungs can hold. And then we'll talk about the other side of respiration, that's perfusion. We're going to talk about pulmonary pressures a little bit, carbon monoxide poisoning, lung compliance, acid-base disorders, just a little bit, because I think we use that enough in the ICU that we should get a lot of those questions correct. Mechanical ventilation, because the exam will have you change vent settings. And then we'll kind of go into what I call the 4 horsemen of the respiratory disease, and that's status asthmaticus, pulmonary embolism, pneumonia, and ARDS. Yeah, let's just review a little bit how much of the exam this covers. It's about 18% of the exam, so almost 20% of those 150 questions. So that's going to be about 27 questions. So vent physiology, ventilation physiology. How does your body normally control the respiratory cycle? You have 4 major control centers within your body for the respiratory cycle. And one of those being the intrinsic drive, intrinsic being the neuronal bodies responsible for your the rhythm, your expiration, and then the modulation of how intense and how frequent that rhythm is. And you see that in the pons as it controls the medulla. So the medulla will create a signal, and the pons will kind of clean that up. I talk a little bit about that in the neuro section when we're talking about pontine infarctions. And then as we move down, we look at the thoracic neuronal drive, and there are more mechanoreceptors, so it's going to be able to sense when there's a problem in the lung, and it can control like a cough, or it can sense if there's vascular congestion and how overloaded the lungs are in terms of volume. There's also peripheral chemoreceptors, so chemoreceptors in the aortic and carotid bodies. They sense more of a hypoxemia, so a low oxygen content, and they become more sensitive in states of hypercapnia and acidosis, but they have a lesser effect than the body's primary responder of CO2. So the body's capable of responding to low oxygen and changing the respiratory cycle that way, but its primary response to changing your respiratory cycle is CO2, and it does that with central chemoreceptors in the medulla. So CO2 forms with hydrogen ions in the CSF, and then the chemoreceptors can sense that in your medulla. An example of this being the case in smokers and truck drivers. You say they become less accustomed to responding to CO2, and they start to utilize more of that peripheral chemoreceptor activity to control their breathing. So when we talk about ventilation, we're talking about the mechanism, the pushing and pulling of the lungs. And all of that's primarily done with the intercostal muscles and the diaphragm, mostly the diaphragm. So when we think about how a person breathes, I want you to think about the physiology and almost the physics of a pulling vacuum, which is what the diaphragm creates. It's attached low on your spine and low on your rib cage, and when that muscle contracts, it pulls down and flattens. And what that does is it creates a sudden increase in your thoracic volume. So that thoracic cavity has a sudden increase in volume. And because the lungs are bound to the walls of that cavity, it expands, creating a vacuum within your body. So it creates a negative pressure in comparison to the outside atmospheric pressure. And so naturally, whatever is on the outside is going to go to that lower pressure, which is your lungs. And now something interesting is that by doing deep breathing exercises, you can actually lower and strengthen the position of your diaphragm. So it's one of those reasons why we use those incentive spirometers in the ICU. We're trying to strengthen their core. So why a lot of athletes, high-level athletes, practice deep breathing and core strength, because it can, by lowering and strengthening that muscle, it can actually improve their core stability. And especially weightlifters do a lot of deep breathing because it helps stabilize their core. And then when you exhale and that diaphragm relaxes, you're lowering that intrathoracic volume, and because of that, the air is then expelled from your body. When we're looking at the ventilation side of the respiratory cycle, there's things that are good to know and things that are like need to know. And one of the good things to know about the ventilation side is our pulmonary volumes. Now, I've got a little list on here. It's not all of them, but it kind of describes how much volume the lung can hold in different states. One of them being, an example being vital capacity, the amount of air expelled after the deepest inhalation. So after you take your deepest breath, how much air can you expel? And that's how much your vital capacity is. That's how much I could say, and if I held my breath and went underwater, that's how much volume my lung could hold and I could use. And there's a fun little picture here that kind of shows these different volumes. There's lots of them, and you can measure all these with basic technology like a incentive spirometer. That's one of the things we use in the ICU, is to measure a tidal volume. We also use it to measure inspiratory capacity, so how much a person can take in one big breath. And you can look up this on the internet and find just the same pattern of waveform describing these different volumes. But it's not going to be something that's on the test. They're not going to ask you how much a patient's functional residual capacity would be. That's something that's more just a nice to know thing. Now, one thing that is important to know, and one thing that's utilized in a ventilator, is tidal volume. And that's something that we normally set. Now, the tidal volume is the amount of air that's moved in a normal respiratory cycle. So me breathing here just now is normally between 6 and 8 milliliters per kilogram of body weight. And that's what you'll set on your ventilator. So for me, weighing about 70 kilograms, that's a normal 140. That would be between 420 milliliters and 560 milliliters. That's how much I breathe normally, or theoretically. Now, a portion of that is anatomically referred as dead space. So a part of that volume is not able to be filtered and taken in through the alveoli and utilized. That oxygen is not. So that's anything between the end of my nose all the way up to that first alveoli. So any of my bronchioles which don't have the capacity to take in oxygen is all referred to as anatomic dead space. And that's about twice your weight, your ideal body weight, in milliliters. So if I weigh 70 kilograms, that's about 140 milliliters within my respiratory system is dead space. Now that's okay, that's normal, that's to be expected. Now, anytime there's alveolar dead space, that's not a good thing, that's pathologic. And we can usually correct that. If it's collapsed alveoli and we're not utilizing that space anymore, or the space is filled with air, but the air or the oxygen isn't able to be taken in through the arterial system, then it's referred to as or alveolar dead space. Now, the other side of the respiratory cycle is the perfusion side. So we have a ventilation of taking in air, and then we have a side of perfusion, which is actually blood coming by the alveoli and taking up that oxygen to actually be utilized. And so without perfusion, ventilation is pointless, right? That's easily seen in a cardiac arrest. There's no point in bagging a patient if you're not doing CPR, because none of that oxygen you're giving is being utilized. So therefore, we measure ventilation, how much ventilation we're performing, and how much perfusion we're performing as a ratio. As healthcare providers, we see that as a ratio to see how effective we are. And that ratio should be about 0.8. We should have more perfusion than we do ventilation. And so when you have a skew in this ratio, and you won't be expected to calculate the ratio, it's very simple. It's just ventilation over minutes divided by perfusion in minutes. So it's referred to as a VQ ratio. You may have heard that before. And so when we have a mismatch ratio, a VQ mismatch, then we need to correct the problem that's causing that mismatch. If it's a perfusion problem, then we need to improve perfusion. If it's a ventilation problem, then we need to correct ventilation. And it's important to know in perfusion that gravity plays a large part in how our lungs are perfused. If you were to lay flat, the bottom half of your lung is going to be perfused. If you were to lay prone, the anterior portion of your lung is going to be perfused. Same thing as if you lay on your side. If you lay on your right side, you would expect about 56% of that blood flow to go to your right lung and about 40% to go to your left lung. Now, it's important, especially when we have patients with weak lungs, either through pathogenic disease or trauma. In the case of a pneumothorax, you want to perfuse the better lung. So you want to put that better lung down so gravity can better perfuse that lung. Something that's also should be known that's not going to be on your test, but it's a good thing to know, is that the lung is perfused in different zones. And the lung is going to prefer to perfuse the deeper zones. And that kind of goes back to that anatomic dead space. You have a lot of large open channels for air to flow into the lung at the top. So the lung is going to preferentially perfuse the lower portions of the lung because there are less large openings and less anatomic dead space in the lower portion of your lung. Now, the only reason we would perfuse all three of these zones is if you're in a state of exercise. So if the body senses we need as much oxygen as possible, then enough collateral flow will happen to where the entirety of the lung will be perfused. But in normal resting states, like you're sitting here, only a portion of your lung is going to be perfused. So the big things with respiratory problems are to stabilize and then identify where that mismatch is. So in the case of desaturating patient, and we're not exactly sure what's going on with that mismatch ratio. Is it a ventilation issue? Is this a perfusion issue? We'll obviously supplement with an increased FiO2, but that might not fix a perfusion problem. So for an example being a pulmonary embolism, where a whole section of the lung isn't being perfused. We can increase FiO2 in hopes to better utilize the lung that is perfused. But if that patient's already using that oxygen optimally of the good part of the lung, then we have to just go and fix the perfusion issue. We have to go out and try to fix this pulmonary embolism. Now, something to know that's just based on pressure when your mouth is open and you're not breathing in or out, you have a normal equal pressure with the atmosphere. But like I was saying earlier, when you take a breath in, you're creating a vacuum. You're creating a slightly lower pressure than the atmospheric pressure. And that pressure's, when you breathe in, is -1, right? When you exhale, you're pushing that out. So your alveolar pressure is slightly higher of +1. And where you'll start to see those pressures come back is when we start to look at a positive end expiratory pressure, a PEEP. And you can apply more pressure to the inhalation. You can apply more pressure to the exhalation to keep alveoli open. So in non-invasive ventilation and invasive ventilation, we can apply a positive pressure to the end of a breath. And what that can be used for is to create a higher pressure to allow more time for gas exchange within the lung. It can be used to recruit more of those alveoli that are collapsed. So what that is doing is essentially improving the functional reserve capacity. That's what it used to be called. PEEP used to be called residual positive pressure, because we're applying a pressure after the breath. So it's pressure that's left over. Now we'll talk about some just basics of oxygenation, right? This oxygen is needed for the electron transport chain in aerobic respiration inside the mitochondria to make an additional 36 units of energy, right? If oxygen is not present, that pyruvic acid is going to be instead fermented through anaerobic respiration to make lactic acid. And that can be used to take off a couple electrons and donate them to try to recharge some batteries. This lactic acid, I want you to view this lactic acid as an alarm clock. An alarm clock that's been going off, and it's almost like a stopwatch, per se. It tells you how long you've been poorly making energy. When you view lactic acid, that's what you should see it as. How long my body has been poorly making energy. The higher your lactic acid is, that's how significant your body is starved from oxygen. And so it's not always corrected with fluid if the issue is ventilation, right? It always goes back to that VQ, that ventilation perfusion ratio. We've kind of gotten into this habit of the lactic acid is high, let's give them a bunch of fluids to try to correct that. But the physiology of that just doesn't make sense, right? It might be a fluid issue, but it also might be a ventilation issue where we're actually not getting in the oxygen that our body requires. So before we go any further into respiratory, I want to talk a little bit more about the basics of oxygen, and we'll talk a little bit about CO2 as well. But when we measure gases, we measure them as pressure exerted on the tissue. So you'll see when you draw your labs or when you draw an arterial gas, you'll see it as PaO2 or PaCO2. That's the partial pressure of arterial oxygen or arterial carbon dioxide. And as we inhale these gases, they decrease in pressure as we get further down into the lung. And that's kind of what helps the gases transfer from the alveoli to the actual blood. So when blood's returned through the venous system, oxygen has a very low partial pressure in the venous system. It's about 40. And then in the alveolar space, the oxygen has a pressure of about 100. So that higher pressure is going to encourage oxygen ions to cross into through the capillary bed and then be transferred off through the arterial system. So the normal partial pressure of oxygen in the arterial system is between 80 and 100. You can check that on a blood gas. And that is at a normal FiO2 of 21%. That's what you and I breathe through the air, the normal air. There's about 21% of the air we breathe is saturated with oxygen. Now we know our normal SpO2, SaO2 should be between 95 and 99%. And if you listen to the hemodynamic lecture, we talked about SvO2, the saturation of used oxygen in the venous system, and that should be above 70% or around 70%, right? If it's too low, that means we're overutilizing or not receiving enough oxygen, and it comes back to the lungs lower. Or if it's too high, it means we're not pulling oxygen off and utilizing it in the cells. Now, something that won't be on the exam, but it's one of those nice to know things, is that the gradient of pressure from the alveolar space to the arterial space should be around 10. So there should be a gap between that gradient. Because if there weren't a gap, then there would be no gas exchange. So the pressure should always be a little bit higher in the alveolar space than the arterial space. So there are more ways to visualize that utilization of oxygen, and one of those being the oxygen dissociation curve. And the big thing we're looking at with this graph is how much of the hemoglobin is saturated. Normally it should be right in the middle here of when we see venous blood, right? 30% of that should have been utilized. That's why when we get our SvO2, it should be around 70%. And so when we have this oxygen come back, let's say higher at like 98 or between 80 and 90% SvO2, then that tells us that our oxygen is being underutilized. So this line shifts to the left when our SvO2 comes back high. And that tells us that our hemoglobin is coming back saturated when it should not be. So that can be in things like a hypothermic patient when their metabolic rate isn't as high. So the oxygen is just staying on the blood. And the opposite can be true when it's overutilized and this line shifts to the right. Oxygen comes back and the SvO2 is lower than 70%. We're utilizing more oxygen off that hemoglobin. And so that can be things in like hyperthermic patients or people who are exercising a lot. So this is just a fun way to visualize the use of oxygen. You'll probably see this in your career again at some point. So while we're on the topic of oxygen, we'll talk about one of the things that you might be tested on, and that's a patient with carbon monoxide poisoning. Now, carbon monoxide is very similar to oxygen in that it binds with heme, except for the fact that carbon monoxide has a much stronger connection than oxygen does. Oxygen has 8 electrons that can be utilized, whereas carbon monoxide has utilized those and bound to itself much stronger, so it's going to fit in to this little cradle of heme much nicer. And it's going to do that at a 230 times greater affinity than oxygen would. So because our hemoglobin is still saturated with either oxygen or carbon monoxide, our SpO2 is going to be unreliable. You may still have a patient with carbon monoxide poisoning have an oxygen or have an SpO2 of 95%, but a lot of that saturation could be bound with carbon monoxide instead of oxygen. And so this carbon monoxide is going to stay on and bound to hemoglobin, preventing hemoglobin from binding with oxygen and getting it to the tissues. So if let's say 40% of our blood is bound to carbon monoxide, then we're only receiving 60% of our normal expected oxygen. And so that's what's so dangerous with carbon monoxide poisoning, is that even despite giving 100% oxygen, our patient truly isn't utilizing that oxygen because it's blocked by carbon monoxide. So what we'll do is measure the degree to which the patient was exposed. Now, you can't necessarily measure carbon monoxide, but you can get an idea of how far they're progressed based on how much carbon monoxide is in their body. And as you start to get more of this carbon monoxide bound to heme, you can see why the symptoms are what they are. So as it starts to bind between 15 and 40%, you're going to get some confusion. You're going to get headaches. And that's because of a lack of oxygenation to the brain. As you get up to 40 to 60%, you start to see loss of consciousness. And then anything above that has an extremely high mortality rate. Now, the half-life of carbon monoxide is about 5 hours. So if you were to just continue to breathe normal air, it would take about 5 hours and 20 minutes for that carbon monoxide to leave and for your hemoglobin to rebind with oxygen. Now, that's okay in someone like a truck driver or a smoker who's constantly exposed to carbon monoxide. You know, they could breathe that off. But when you start to get to these higher levels, like you see in people in the north who leave their cars running in their garage, and they go in and they inhale a lot of this carbon monoxide from exhaust, then we need to start supplementing their oxygen to try to quickly grab that hemoglobin that is freed up by expired carbon monoxide. So, and hospitals that don't have hyperbaric oxygen chambers, we'll just put them on 100% FiO2, and by utilizing more oxygen in the space, we can cut that time from 5 hours to about 1 hour, or 1 to 2 hours. Now, if you're able to get a patient into the ER quickly who's been exposed to carbon monoxide and put them in a hyperbaric chamber, what that does is we seal them and set the atmospheric pressure to 2 to 3 times normal atmospheric pressure. And what that does is over overexposes those alveoli to oxygen. And we can cut that time to about 20 minutes. Now, it's important to know that this medicine, this type of therapy, is only useful if you do it right away. Right? If someone's been exposed to carbon monoxide, but we found them breathing outside because they stumbled out of their garage and then we found them breathing 2 hours later, then it might be easier to just continue to treat them with 100% oxygen. Another thing we want to look out for when we have a patient on a ventilator and we're administering breaths is this idea of lung compliance. How compliant are the lungs to being stretched? And we can measure that by dividing the tidal volume from the plateau pressure or from the peak inspiratory pressure. And inspiratory pressure is used for airway compliance, whereas plateau pressure is used to measure lung compliance. So you can see on this image, as we were talking about earlier, this idea of a tidal wave. You have your peak end expiratory pressure. That's the ventilator set. You can set that ventilator to have a steady state or static end pressure. And then as we reach this peak inspiratory pressure at the end of an exhalation or inhalation, we want to keep that below 40 centimeters of water. So at some point you have to stop the excessive driving force of that breath to avoid barotrauma. So acid-base disorders, we're very, very aware of these in the ICU. We do this all the time. We're checking blood gases and comparing them to previous ones, or we should be. And one of the important things to know with acid-base disorders is what's the compensatory measure to fix the problem naturally. So in the form of respiratory acidosis, the problem is we have too much CO2, so the body retains more bicarbonate in order to make carbonic acid with the CO2. Metabolic acidosis is a lacking of bicarbonate typically, and what we can do is correct the acidosis by exhaling more CO2. Respiratory alkalosis, problem is we have too much exhaled CO2, so in a hyperventilatory state, what we can do is encourage the secretion of that bicarbonate. And then finally, metabolic alkalosis is we have a state of retained bicarbonate. So if we have too alkalotic of a state, we can increase the acidotic state by decreasing the respiratory loss of that acid or carbon dioxide. So a true normal pH, we want to be right at 7.4, true normal CO2 at 40, and I like to reverse how my CO2 is displayed because a high CO2 is acidic and a low CO2 is basic. A true normal bicarbonate is 24. And it's something interesting. If the concentration of your hydrogen ions goes up, then why does your pH go down? And it doesn't make too much sense, but the way it's displayed mathematically is you take the log, which is a negative, of these hydronium ions, which hydronium ions are what is essentially the hydrogen ion. The hydrogen ion will bind with water, and the more it does that, the more the pH goes down. So it's confusing on why the pH goes down when there are more hydrogen ions, but that's why. But the last thing we talk about in an acid-base disorder is this idea of an anion gap. And those are most often seen in a metabolic acidosis, like in a DKA, where there's a large increase in the difference between positive and negative ions. So you won't have to know the calculation. It's there for you if you want to know how to use that on your unit. But it should be normally between or below 15. So between 5 and 15. So anything above that, you would say the gap is open. and you would try to correct that. All right, so ventilator basics of mechanical ventilation. These are things that probably won't be on your test, but are just good to review. Normal cuff inflation is about 20 centimeters of water. And that tip of that ET tube should be about 3 to 5 centimeters above the carina, that split in the bronchial stems. And if it's too far, if it's placed too far, it'll migrate down to that larger right bronchus, and you'll get a right main stem intubation. And they'll ask these kind of questions in like CRNA interviews. You know, you've intubated, your patient goes hypotensive and hypoxemic. What's the problem? And usually they're looking for you've intubated too far. Withdraw the tube a little bit, administer something to correct the blood pressure, and reventilate your patient. Something to note is that with a trach versus an ET tube, there's a much larger degree of dead space, where we talked about that anatomical dead space, that space between the alveoli and your nose. Well, with the ET tube, it adds space to that because of the tubing of the ventilator system. Now it's less so with the trach because that airway is much smaller. But anytime you intubate, you're going to have an increase in airway resistance because that tube is solid and it does not flex. So that's why it feels anxious to breathe through, because it's tight, it doesn't stretch, it feels like you're breathing through a straw. All right, so we'll talk about some ventilator settings, and we'll just talk about a few because there are lots of types of vent settings, and there are lots of names for vent settings, even though they do the same thing. And one of the ones we use for total control, total respiratory assistance, is known as assist control, AC. And that's where you set a tidal volume, typically that 6 to 8 milliliters per kilogram, and you set a breath rate at a specific rate. So what that will also do is anytime the patient triggers a breath, so anytime they create a negative force on that ventilator tubing, the machine will sense that they are trying to take a breath and give them that entire set volume. So all of the breaths that the machine gives or the patient tries to take are from the machine. So it'll always be at the set volume we program into the machine. So the patient could do absolutely nothing and be completely okay from the ventilator doing all the work. However, if the patient is over breathing, if the patient's set is breathing maybe 27 times a minute and we set them to 14, lowering that ventilatory rate isn't going to do anything because the patient is triggering their own breath. So what we would have to do is most likely sedate them or figure out why they're over breathing. So the problem with this setting is that you can easily hyperventilate if the patient's awake and anxious or hurting. It can also hyperinflate the lungs. If they're taking too many breaths at this high volume we've set, then you can hyperinflate the lungs. The next setting is known as synchronized intermittent mandatory ventilation, or SIMV. And this vent setting is very similar to assist control, but allows the patient to do some more work for themselves. So it'll still administer a set tidal volume, so still administer that 6 to 8 milliliters per kilogram at a set rate. So we'll still set the rate, but anytime the patient triggers a breath, it'll allow the patient to take as much volume as they want, or as they are capable of doing. So in addition, the machine will also synchronize to those breaths, so it will try not to hyperventilate the patient if possible. So it still provides full support, so you can still make sure that if the patient does nothing, then then they're taken care of. But it'll allow the patient to do some work on their own, especially if you reduce the rate down a little bit lower, knowing that the patient can do some work on their own. Something you can do with this vent setting is make sure that the spontaneous breaths that the patient is taking are supported by a little bit of pressure. So you can add some pressure to those breaths. Now, a mode that we use for weaning patients off of the ventilator is known as pressure support. So in this mode, the patient does a lot of the triggering of the rate, of how much volume, of how much flow rate they take in, and how long their breath is. And the machine, all the machine will do is make sure that they have enough pressure behind that breath. So it's very convenient for weaning towards extubation and adding that pressure to overcome like just the resistance factor of the tube itself. So the patient can still breathe on their own, but doesn't feel like they're trying to suck air in through that idea of a straw. So that's more so what the pressure is for. But it's a very good mode for weaning towards like a CPAP. So now, what's the rationale behind changing some of our vent settings? Now, it can't be, well, get the respiratory therapist or ask the provider, because as a critical care nurse, the ACN wants you to be critically thinking and understand these concepts of why the patient's getting certain tidal volumes, why the patient has a certain breath rate or FiO2. And for us to critically think about that, we have to know why we're changing these rates. So as far as a breath rate goes, we're changing that based on what the PaCO2 is from our blood gas. If our PaCO2 is a lot higher, then that means we're acidotic and we need to increase the rate. We need to blow some of that CO2 off potentially. If we're looking to change the tidal volume, we have to remember that it's based on the ideal body weight. We talked about that. And then anytime in an ARDS patient, or if the patient has high airway resistances, we want to avoid large tidal volumes. So potentially decreasing that tidal volume to 4 or 6 instead of 6 to 8 to avoid any kind of high inspiratory or plateau pressure. And then our FiO2, our inspired oxygen, and we're changing that based on the partial pressure of oxygen. Now, we would change that if the issue is ventilation, but if the issue is perfusion, then it's going to have little effect, right? We've got to correct that issue of perfusion first. If your patient has a PE, increasing the FiO2 may help a little bit, but in the grand scheme of things, the issue is perfusion. Now, I'll be a little silly here with this picture, but there's some seriousness to it. But this picture shows an intubated patient with no restraints on, no ETAB, probably not sedated. I don't really see any propofol hanging. And the idea is this patient's probably going to wake up and self-extubate at some point, right? And what the key thing is that we need to check every time we walk into a room at the start of our shift is, where's the ambu bag, right? Is it on the wall? Was the room properly set up, and is it there? Is it open and ready to be attached to the vent or the ET tube in the case that your patient's vent is not responding well or alarming and not giving breaths we need to be giving? Or does the patient self-extubate and you need to give mask ventilation, but you have the bag, but you don't have the bag mask? So those are things to always check for when you go in. You might have an ambu bag hanging, but you always want to make sure that the mask is there too in case they self-extubate. Okay, so the last part of this respiratory review is what I refer to as the 4 horsemen of respiratory disease, and that's asthma, status asthmaticus, pulmonary embolism, pneumonia, and ARDS. Now, these things are very dangerous if we don't treat them well or recognize them quickly. So we're going to go through each one and kind of identify what the questions could potentially be on their exam and how you could better take care of these patients in the ICU. So status asthmaticus is this idea of a genetically predisposed person responding to an allergen, either one they've already been exposed to or a potentially new one, and we're utilizing the humoral immunity rather than cellular immunity. So we're taking B cells to make antibodies to recognize pathogens like dust or mites, and instead of using macrophages, we're using the mast cells, which create a histamine response, or using cytokines or leukotrienes to kind of combat this allergen. So what those histamines and cytokines do is they're going to bind and cause the smooth muscle spasms of the bronchioles. They're going to cause inflammation and edema within those tissues, and it's going to cause increased secretions to try to flush out a lot of those allergens. And so what that results in is your airflow obstruction, right? You end up having a very tight airway, decreased ventilation. We think about that VQ mismatch ratio. We're thinking about ventilation here. And that's going to cause hypoxia and air trapping as a result. We're going to be able to take in breaths, but it's going to have a lot harder time to get out. So as a result, the hypercarbia, or we get a higher CO2 because we can't exhale as well all that CO2. And then later, in an asthmatic state, we're going to start to see hyperinflation of the lungs because that air gets trapped. And we're going to have a reduction in venous return as those lungs become higher and higher pressure. It's going to eventually cut off a lot of that blood flow from reaching the left side of the heart. So that's where you could eventually get your cardiac arrest when you have an asthma attack. So what we can do to sense how far their asthmatic attack has progressed is we can look at the CO2. It'll often start alkalotic and then move towards a more acidotic state. So the further we get into an acidotic state, respiratory acidosis, the worse we know it is. So what we can check is a peak flow rate. We can have the patient breathe through a little device, or if they're already intubated, we can check how much flow rate is coming out on exhalation maximally that the patient is able to produce, and we would expect that to be less than 80%. Now anything less than 50 is very critical, and if they're not intubated, they definitely should be. That's one of the key things with asthma attacks, is avoiding a difficult airway intubation. So the first signs of a level of consciousness change, which is caused by that CO2 retention, we want to intubate. And we really want to avoid sedatives if possible. Anything that's going to distract us from how bad their respiratory state is, we want to avoid. So we're going to use bronchodilators, potentially like albuterol and then ipratropium bromide. And then we'll give corticosteroids like fluticasone, and that's going to mask a lot of those, that immune response, that humoral immune response, the mast cells, eosinophils, T cells, and try to reduce that histamine response. And then any kind of chance we can get to hydrate the patient is going to help thicken those, prevent the thickening of those secretions. Because that's another thing that's going to impede our airway, is any kind of blockage, mucus plugging. And so when you have your status asthmaticus patient and they're already intubated, we want to keep a lower rate to improve the exhalation time. So if we can improve how long they're exhaling and ensure that they're getting rid of that CO2, that's wonderful. We also want to have a lower tidal volume to prevent any of that air trapping, excessive air trapping. If we're pushing in and and really forcing in this air, and then it's not able to come out, we're going to get something called autopeep, or trapped pressure at the end of exhalation. It's going to be trapped, and that's what's going to lead to your barotrauma, your pneumothorax. And then going back to that idea of a longer exhalation time, we'll try to set a high IE ratio, a high inspiratory to expiratory ratio. And usually that's between, the ratio is 1 to 3 or 1 to 4. So for however long that inspiratory rate length is, then we want the expiratory rate or length to be 3 or 4 times that, to allow for significant exhalation time. We want to get rid of as much CO2 as possible. So one of the next things we'll talk about is the idea of a pulmonary embolism. Now these are either labeled as massive or submassive, so any kind of occlusion over 50% of an artery, we're going to call that massive. Anything under 50%, we're going to call submassive. Now, 80 to 90% of these PEs are results from DVTs, which is often why surgically they'll place an inferior vena cava filter or an IVC filter to catch any of these potential DVTs if the patient has a history of this. And then this starts as a perfusion issue, but eventually affects ventilation. And then we'll go into why. But there's this triad here. We can see of people that are predisposed to pulmonary embolisms. And it just shows obesity and pregnancy on here, but there are other ways to be exposed to stasis, for example. So decreased venous return, decreased mobility. That doesn't necessarily mean you have to be obese. If you have a patient that's bedridden and they don't have SCDs on for a week, that's going to contribute to their risk for DVT and eventual pulmonary embolism. Any kind of endothelial injury, any kind of trauma that a patient comes in for, and then any kind of hypercoagulative state. So especially in pregnancy, we want to keep an eye and think about all these kinds of things that could place our patient at risk for a pulmonary embolism. So I have this great image here, this PDF of an example of the pathophysiology of how pulmonary embolism works. I know I didn't create this. This was about 20 years ago this was made, but it shows really well just the basics of what a pulmonary embolism and how it develops and how it both affects the ventilatory side and the perfusion side. So we looked at that Virchow's triad, those 3 things that can increase your risk for a deep vein thrombosis. And then we talked about the large, the submassive, and massive PEs. So the central PEs, the massive PEs, are going to be in those larger vessels. And the peripheral ones, those submassives, will be closer to the pleural, the outside. And so when we look at a big, large central PE, one of the big things we're going to see is this idea of mechanical occlusion, of this occlusion of our large vessel, and it's going to create that pathological dead space that we talked about, that alveolar dead space. We have the anatomic dead space that we can't help, and then when we get something like this, a PE, where all of these alveoli are no longer perfused, we get this dead space that compromises our VQ mismatch ratio. Okay, and once you stop perfusing those alveoli, you end up getting, those cells can end up dying, those type 2 pneumocytes, and then it can start to form less surfactant and start to form atelectasis, which then becomes a ventilation issue. So when you're looking at pulmonary embolisms, you got to remember it starts as a perfusion issue, and if it left long enough to where those tissues start to die or are ischemic, then it starts to become more of a ventilative issue, and it's a lot harder to compensate for. So I'll just let you look at this image, or you can pause the video. But this does a good job of showing that VQ mismatch and how initially the clot will block perfusion, And eventually that vascular compromise leads to atelectasis and alveolar hypoxia, and those cells start dying and creating a ventilation issue. So we talked about DVTs causing PEs, but there are lots of other ways, not as common, but that can cause PEs. So we can see fat emboli after long bone or a hip fracture. Also the catheter, any kind of catheter that's dislodged and ends up passing through the right ventricle can be dislodged and cause an embolism. Any kind of clot in the right atrium or ventricle can travel to the pulmonary system and cause an embolus. Amniotic or any kind of tumor can cause a pulmonary embolus, and then septic emboli. We can get a large infectious material breaking off and ending up in the lungs as well. So one of the best ways to visualize where the clot is and figure out how to get rid of it is through pulmonary angiography. So we can inject a dye and see exactly where the perfusion is being stopped and see what tissue is no longer perfused. We can also draw a D-dimer lab. Now, it's not as inclusive because a D-dimer shows the breakdown of clots. So when we're thinking about DIC, that's very definitive of DIC as a D-dimer. Whereas this, it may hint towards it, but it does not necessarily rule it out, right? You could have a clot elsewhere, but it does help identify it. So they've been known to use high-speed CTs to try to catch where the clot is, but that hasn't been used as much in research. And a lot of times these smaller PEs aren't even ever diagnosed. Somebody will go into respiratory failure, we'll compensate them for a while, and then their body will kind of get past that initial injury, and will have never even known that they've had a PE. It's preventable, right? You can prevent DVTs with low molecular weight heparin or unfractionated heparin. Any kind of intermittent pneumonic compression device, those IPC devices at the end of the bed, SCD devices, can help squeeze and prevent blood clots from forming in the calves. And anytime it's confirmed or highly suspected of a PE, heparin or sometimes Coumadin is even started. And at times TPA, using this fibrinolytic therapy, is used, but more so only when they have a large hemodynamic compromise. So when you see blood having a hard time getting to the left side of the heart and you have a subsequent drop in cardiac output, that's sometimes when TPA is considered for a PE. Okay, so we'll move on to pneumonia. This is the second of the four we're going to talk about. And we know that there's bacterial pneumonia, viral, fungal, and sometimes parasitic, and that they're either community acquired or hospital acquired. Hospital acquired is a much higher mortality. And so when we're thinking about bacterial, we got to think that the pathogen is growing within the alveoli, and it's going to grow better when it has water or some kind of nutrient to feed off of. So anytime any kind of aspiration event is definitely going to increase the risk for bacterial pneumonia. And so what will happen in bacterial pneumonia is these capillaries will open, allowing macrophages to end up entering the cell or entering the alveoli. That's the cellular immunity. And it's going to reduce the bacterial load, but it causes a lot of congestion and edema by doing that. So that's where you start to see things show up on X-ray. Viral pneumonia is a little bit different. The virus is going to enter the actual pneumocytes, the actual cells of the alveoli, multiply, and then lyse the cell, destroy the cell. So what these lymphocytes are going to do is they're going to respond to these cells exploding, and they're going to go and try to dismantle the cells that are infected and try to control the virus. So anytime in pneumonia, we really want to optimize that ventilation and perfusion ratio, and we can just treat naturally with FiO2, but we really want to be focusing on what's the problem here. And something that we talked about earlier is the importance of lung perfusion and based on gravity. So with pneumonia, sometimes they'll have bilateral infections or bilateral lobe pneumonia. Sometimes they'll have just right lower lobe pneumonia. And so what we want to do is focus on putting that good lung down, perfusing that with gravity, perfusing the better lung while we try to treat and correct the other lung that's having trouble. So we can do this in addition to positioning. We can promote bronchial hygiene, and a common term that's used in medicine is respiratory toileting. So any kind of chest physiotherapy of the bed, shaking the bed will help. Using an incentive spirometer of strengthening that diaphragm and those residual volumes of our patient. Using an a cappella device, it looks some of them they're like green, and what they use is this positive expiratory pressure therapy, this PEP therapy, where it has a little flutter device, and what that does is it kind of mimics the act of the ciliary within your lung tissues, and it vibrates and allows all that mucus and that dead bacterial matter to kind of come up and allow the patient to cough it out. Sometimes in serious states, they'll use bronchoscopy with lavage to try to clean out those alveoli. And then obviously with any kind of infection, you want to draw sputum culture, you want to draw blood cultures and start empiric antibodies. That's your first initial, based on evidence, what do we think this is? And it might have to be a broad spectrum until we can get those cultures back. Well, we want to start those early to try to stop the multiplication of the bacteria, try to stop a significant immune response, which is going to worsen our pneumonia. So the last topic we're going to talk about in respiratory before we do some questions is acute respiratory distress syndrome, or ARDS. And this is a condition that is triggered by an inflammatory response, which ends up causing a lot of fluid in the interstitial space, so that space in between the alveolar and intravascular tissue. And it can also be in the alveolar space, and what that's going to end up causing is some damage to those alveolar, those type 2 pneumocytic cells. And so as a result of those being damaged, they're going to produce less surfactant, and they're going to collapse, which is going to cause some significant atelectasis. So the big thing that's dangerous with ARDS is that because we lose a lot of that ventilatory side of the respiratory cycle, that VQ mismatch, we're going to find that oxygen is often refractory. We can increase the FiO2, but if we don't have any space for that gas exchange, then it's not very effective therapy. So what we're going to do, the mainstay treatment for ARDS, is recruiting those alveoli back using PEEP. So in order to diagnose ARDS, we need it to be in both lungs. So we need infiltrates or atelectasis in both lungs. And we need a high pulmonary artery occlusion pressure. So that's telling us that there's a lot of pressure that's causing poor perfusion to the left side of the heart, poor blood flow to the left side of the heart. So you can see a lot of hypotension with that as well if ARDS is bad enough. And the last thing we're going to look at is this idea of a PF ratio, this partial pressure of oxygen in comparison to how much oxygen we're providing. So if we're providing 21% oxygen, which is nothing, and the person's PaO2 is 80 or 100, which is normal, then they should have a normal PF ratio of 400 to 500. Now, if they're 80, their PaO2 is 80, and we're supplying 50% FiO2, then we start to have a problem, and we want to address that. But in order for ARDS to be diagnosed, we need it to be below 200 millimeters of mercury. So in order to treat and try to resolve this acute respiratory distress syndrome, we're going to need to apply a lot of PEEP, or positive end expiratory pressure, to try to resolve that loss of alveolar space and regain that alveolar dead space. So we'll probably need to intubate, because we can't really obtain a high PEEP without a way to control it. And so we'd intubate, and we set the PEEP to a fairly high level, which is, it's usually above 15. Now the problem when we have a high level of PEEP, or a high level of pressure at the end of an expiration, is that we can cause some barotrauma when we then administer another breath. So anytime we have also a high PEEP or a lot of pressure in the lungs, we're also going to further restrict that blood flow through the lungs and back to the heart. So we're going to end up seeing a potential decrease in cardiac output, which translate to a lower blood pressure. But because this issue is so significantly refractory to oxygen, and that we need oxygen, we need to make sure that we are maintaining that PEEP despite a potentially low cardiac output. So we might have to modulate output with a pressor or fluids, so that way we can maintain our PEEP. So what we will do as nurses too, is recommend that the patient's tidal volume, if it's still high, if a normal 6 to 8 milliliters per kilogram, be turned down to 4 to 6. And so what that's going to do is limit the amount of new pressure added at the start of a new respiration, when there's already a lot of pressure in there. So anytime that we lose that pressure, usually through the form of a vent disconnection, so if you have to travel somewhere, or if the vent gets disconnected while turning, we lose a lot of that alveolar recruitment immediately. And some of that might take a long time to recover, because in the alveolar system there's a lot of collateral connections between those alveolar sacs, and so we may have gotten really deep in the lung with using our PEEP, and if we lose a potential air sac higher that's connected to a lot of air sacs lower, then we've lost that whole part of that lung again. And for this reason, and for the reason that they're hypoxemic, a lot of these ARDS patients end up passing away from multi-organ failure, just because they're not being properly perfused and getting the oxygen that they need. So one thing we can do to help them is potentially provide nitric oxide that'll come in a big tank, and it's a different type of gas that we can give that readily crosses the alveolar membranes. And what it ends up doing is it works a lot like the nitrates we give in an anginic state when we have chest pain, and that it will come in and it will dephosphorylate the myosin heads and allow them to relax. You can see in this image here how nitric oxide ends up causing that, and what that's going to do is end up helping in the ventilation and perfusion ratio, which is ultimately how we maintain a stable respiratory cycle. So you can see, as we talked about a lot earlier in the presentation, how important it is, or how important gravity plays an effect on our perfusion of our lungs, that we've made technology to help with that perfusion. And one thing that we can utilize is this technology called a rotarest or rotaprone bed, and that we turn our patients a lot more frequently, to a lot more significant angle, and we're going to perfuse different parts of that lung that would not normally be perfused. So to give the posterior part of the lung a break, we can turn our patients to the side, or we can prone them with one of these beds without having to put them through the rigorous proning process without one of these types of bed like we did in COVID. And that'll much better perfuse the lung. Now, you probably won't see these. I haven't seen one of these in 4 or 5 years. So it might just be hospital specific, or they might have just gone out of practice. So, but they are useful, and they do have a clinical relevance in ARDS especially. So the big thing to spend your time on that I did not cover, just for a short amount of time, review aspiration. They'll probably ask a question on preventing or resolving aspiration. We talked about it a little bit with how carbon dioxide is the driving force, but in COPD patients, it can become oxygen to an extent. So when we're giving a high amounts of FiO2 to someone who has COPD, then it can almost decrease their ventilation rate, causing them to have potentially more confusion from a buildup of CO2. So that's something to consider. And then occasionally, if you work in a medical ICU, potentially other ICUs, you'll see people come in with pulmonary hypertension and they're on a very specific medication, IV. And a question they'll probably ask on the exam about this is making sure to always have a second IV set up in case that one were to become either empty or come disconnected and infected. Then we can quickly switch and make sure that they stay on their needed medication. And then finally, pneumothorax, definitely spend some time on this. They'll ask questions about chest tubes, malfunctions of chest tubes, how to resolve issues, what those problems mean. So just remember to spend time equivalent to the likelihood of seeing the content on the exam. It's a 150 question exam. We know that respiratory is a fairly large portion of it. But you'd be better off spending more time if you have limited time on something you're more likely to see. So our first question, which of the following is an appropriate intervention for a patient with status asthmaticus on a ventilator? What's the most appropriate intervention? Would you decrease the peak flow rate? Would you potentially increase the tidal volume? Would you check for auto PEEP? Or would you increase the breath rate? Remember, this is a status asthmaticus patient. What's the most appropriate thing? So the thing we're thinking about with the status asthmaticus patient is that because those upper airways are becoming constricted and blocked, that when we end up giving a breath, especially if they're on a ventilator, that air starts to become trapped if we're not resolving that airway constriction. So what's going to end up happening is pressure will start to slowly increase. And I'll show you an image of what that looks like on some of these ventilators. But what that can do, it can decrease cardiac output. Anytime you increase PEEP, you can decrease cardiac output. So what we need to do is make sure we're checking for auto PEEP, and this is what it's going to look like potentially on a ventilator. You're going to see on the top here your pressure that bottom pressure, that end expiratory pressure could potentially start to slowly increase. Your tidal volume, that end of that tidal volume as it's exhaled may still not equate to what was initially placed in the patient. So 500 milliliters was placed in the patient and you only get 480 out. It shows that you have some air trapping. So this is something to just look at if you're actually on the unit and monitoring a patient with asthma or anyone who's at risk for air trapping. Next patient or clinical question is, you have a 70 kilogram patient who's intubated with ARDS, but they are properly paralyzed on a continuous vec drip on the following vent settings. So you have an ARDS patient who's about 140 pounds, who's paralyzed. Their peak inspiratory pressure is 55, and their plateau pressure is 50. And I'll remind you that a normal peak pressure, inspiratory pressure should be below 40, and a normal plateau pressure should be below 30. So those are some numbers you probably want to remember. The patient's PaO2 was 60. Their rate is 12. They had a tidal volume of 700. Their FiO2 was 100%. They're set at a PEEP of 15, and they're on assist control mode. So the nurse knows which of the four following. The tidal volume should be lowered. The PF ratio indicates that the patient is actually no longer in ARDS. Remember that PF ratio is the partial pressure of oxygen in comparison to the FiO2. The PEEP should be lowered, or the respiratory rate should be increased. So the concerning thing with this is that the peak inspiratory pressure is very high. It's above 40 at 55. The peak the plateau pressure is above 30. It's at 50. And the PaO2 is still low. It's only at 60, despite a high fraction of inspired oxygen, or FiO2. So what that tells us right away is that the patient is still in ARDS because their PaO2 is not responding to the therapy we're giving. The PEEP is adequate, thus that we need to keep giving them respiratory support to try to open those alveoli. But the big concerning thing is that the tidal volume, the amount of air we're giving, is causing a lot of pressure. So because we already have a lot of end expiratory pressure at the end of the breath, then once we're administering another breath, we're causing too much pressure because there's already too much pressure. So the resolution to this would be to lower the tidal volume to avoid barotrauma. So that's the big concern with this patient, is that their inspiratory and plateau pressures are too high, which could eventually cause some trauma. And here's just the image to remind what that peak inspiratory and peak plateau pressure look like. So our last question, what would be considered the earliest sign of hypoventilation? Earliest sign of hypoventilation. An increased respiratory rate of 20, anxiety, SpO2 of 85%, or a decreased level of consciousness. So this can be a tricky question, and they might do questions like this on the exam when they're asking for something very specific. They're asking about carbon dioxide here. And they give you 3 answers that are based on oxygen or hypoxemia. And what they're asking is a question about hypercapnia or hypercarbnia, the high CO2. So anytime you have a high CO2, it's going to cause a lot of changes to cognition. So anxiety, an increased respiratory rate, a low oxygen could all be potentially signs of hypoxemia. But a patient with hypoventilation necessarily won't have hypoxemia. If I were to just take very slow breaths, my body might not necessarily go or become hypoxemic. So That's one thing to keep an eye on, or keep a close eye out for, especially later in the exam when you start to get test fatigue. Is what exactly is the question looking for? What are the words specifically pointing towards it? In this case, it's towards carbon dioxide. So thank you for sitting through this lecture with me and hopefully learning something. I wish you the best on your exam.